Testing.
Sorry, I think Dr. Go has some problem logging in. We just give her like 5 minutes like that.
Sure.
Hi.
Hi.
Hi, sorry for being late. Hi, Gary.
Hi.
I was like, why I cannot access to my Zoom? Hi, Dr. Liu. Sorry for being late.
Sorry. It's okay. Hi, Dr. Go.
Yeah.
Right.
Yeah.
You, Dr. Go, Dr. Gary, ready? We can start now.
Yes.
Okay.
All
All
right.
right. Good afternoon. Good afternoon, everyone. Welcome to this weekly webinar organized by the College of Physician Malaysia. And this is a month of dermatology. We are at the week 4, last week for dermatology. And today's topic will be approach to hypopigmented skin lesion. We are very fortunate to have us with here today distinguished speaker Dr. Gary Chia Jin Chin, and also our chairperson Dr. Goh Siu Wen. So without further ado, let me just briefly introduce Dr. Goh. Dr. Goh graduated with a Bachelor of Medicine from University of Southampton, UK, and also went to did housemanship in Singapore GH. She was then subsequently become a trainee in internal medicine, practicing in Changi General Hospital, and subsequently transferred back to Malaysia and practiced in Hospital Sungai Buloh. Proceeded to obtain NRCP UK and become a general physician, practicing medicine in Hospital Sungai Buloh and also Hospital HTA in Klang Valley. So subsequently, she also underwent dermatology training in both UKM and Hospital Kuala Lumpur. And she did briefly serve as a consultant dermatologist in Hospital Sedang. And currently, she is practicing in the skin-centric Bukit Tinggi Medical Center in Klang. Without further ado, I will pass the floor over to Dr. Goh.
Thank you, Dr. Liu, for the elaborative introduction. Allow me to introduce our speaker, Dr. Gary Chia Jian Chin. He's a consultant dermatologist and head of department at Hospital Pakar Sultanah Fatimah Muar. So his interests are in contact dermatitis, allergic skin diseases, and patch testing. So Dr. Gary, he involved in several multi-center clinical trials, and he contributes to the development of National Contact Dermatitis Registry. He is also a reviewer for our Malaysian Dermatology Journal of Dermatology and the Journal of Asia Pacific Aesthetic Science. So he actively sharing his experience through talks on topics, especially like acne, lupus, occupational skin diseases. And today we are so honored to have him to talk to us about hypopigmentation, which is a very common condition seen in our population. Without further ado, let's proceed, Dr. Gary.
Right. Okay. Thank you, everyone. Good evening, and thank you for joining. I'm Dr. Gary Chia from Hospital Pakar Sultanah Fatimah, and we're going to talk about hypopigmented skin lesions. This is one of those common but deceptively simple presentation. Now, every internist at some point will have seen them, probably a patch on the face or a pale streak on the body, maybe some lines or some spirals on the back. And many of us, we instinctively reach for fungal infection as one of the more convenient diagnoses. But really, not every white patch we know is tinea related. So today, we're going to go through a practical and clinical approach to how to approach and diagnose hypopigmented skin lesions. And perhaps we will find something useful for everyone at the end of this lecture. All right, so let's start. So this is my department. I'm the head of department for Hospital Pakar Sultanah Fatimah Muar, and I cover a few other hospitals in northern Johor, and this is my team. So what we're going to do is we're going to talk about recognizing certain clinical patterns and then the differentials, common diagnosis, and also performing simple tests and identify when to refer. So by going through this, I hope that everyone would be able to be more comfortable handling hypopigmented lesions. So let's start with the basics. What gives our skin color? How does one person appear lighter skin and another person have perhaps a darker skin tone? So the whole story starts here at the bottom of the skin, the melanocytes. So melanocytes, they reside at the basal layer, and they are cells that produce pigments that we call melanin in our skin. And this is a melanocyte here. It resides at the bottom of the skin, and you can see that it has sort of a tentacle that reaches out into the deeper parts of, not really the deeper, the upper parts of the skin into other skin cells. We call them keratinocytes. And if you were to notice all of these dark brown, these are the melanin pigments in melanosomes, which are the transport medium for them. And from here, the melanins are being transported to the upper part of the skin. And melanin synthesis is actually quite a complicated process. Okay, so what takes place within the melanocytes are a process where they change thyroxinase into other forms. And then there are a few enzymes along the way. Thyroxinase is one of them. So they change thyroxine all along, and then they produce melanins. There are two types of melanin: pheomelanin, which produces our yellow and red color. Eumelanin produces brown and black. So over here we have two individuals, one with a darker skin type and one with a lighter skin type. Who do you think has more melanocytes? Now the answer most people would think would be the darker skin person, but interestingly, both of them will have the same number of melanocytes. Everyone will have a ratio of 1 melanocyte to 36 keratinocyte. So over here, this we see as a picture that is one dimension. So imagine this in the 3-dimension a configuration. So not just this 1, 2, 3, 4, 5, 6, 7, but actually to 36 front and to the back. Okay, and the difference between those two individuals just now is the amount of melanin being produced by the melanocytes in their skin. And that will color the fabric of their skin. Right. So let's get used to some terms. So we have normal skin, and then we will have hypopigmentation, where there's partial loss of melanin. When you have partial loss of melanin, your skin will look from a darker shade like that to a lighter shade. And then there's total loss of melanin, where there's complete white area, okay, almost complete white area. And that is what defines depigmentation. And this is how it will look like as an end result. All right. So the mechanisms for this to happen would be, first of all, it could be a loss of your melanocytes just now, or it could be a problem of, perhaps it's a problem of the melanins itself not being produced enough, or the melanins are being produced but it's not being transported out of the cell and to color the rest of our skin, right? So that is the probable mechanisms for it. And why does all of this matter is because 1 in 20%, they're actually affected by hypopigmented or depigmented macules. And the condition is often underdiagnosed or maybe overtreated, repeatedly treated for fungal infection. And besides that obviously cosmetic difference, it also causes social and psychological distress. I know many of us think that beauty is from the heart, we look within and not outside. But if if just say you were to open a business or a clinic and you have two applicants, one normal looking and one with patches that are depigmented on the face, who will you pick first? So uh, I would say that people who are affected by this, they sometimes are not afforded the same employment or life opportunities as others. So when we first see a patient like this, we will have to take some history. The age of onset is important because a younger age will point towards something more congenital or maybe a milder form of eczema, whereas an older age group, an adult, we will think of something that's acquired or maybe a disease that starts later in life. In terms of race, our darker skinned patients tend to manifest these lesions more apparently, and they are more prone to hypopigmentation uh, when exposed to certain chemicals. And then there's also the onset and evolution, whether it's sudden onset or something of a gradual process, whether the disease is stable or progressing. When it's progressing, we will think of an inflammatory or infective nature of the underlying mechanism. And then, other than just looking at the skin alone, other clues like itch, sensory loss, photosensitivity, systemic symptoms may point towards an infective diagnosis or even something syndromic. And of course, we will have to get a history of the exposures to chemicals, things they use, drugs they use, or even history of travel, which might point towards other type of infection. Right. So after the history, the first step that we should do would be to confirm true hypopigmentation. We look at the skin and compare it with the surrounding skin under natural light. And then we use Wood's lamp to actually compare the lesion. Okay, Wood's lamp will accentuate certain parts of the patient's affected skin, giving it different type of lighting. So in depigmented lesions, we have bright white. Hypopigmentation, we might see a faint white, whereas a fungal infection might show you a yellowish green tinge to it. This is Wood's lamp. Wood's lamp is actually a convenient bedside device that you can use and to highlight the hypopigmented or depigmented patches. It carries with it ultraviolet B light, specifically 365 nanometer in wavelength. So how do you use it? So for example, you have a patient in front of you in a room light that he says that he has some hypopigmentation around the eyes, or maybe it's not so obvious, and you're not very sure whether he is just being picky or being fussy, right? So if you have a Woods lamp, a classical Woods lamp would accentuate that depigmented area. Over here, you can see that it's actually quite brilliant white. Now, in a better Woods lamp with just 365 nanometer, it becomes even more obvious, right? So that's the utility of a Woods lamp. So having done that, we might want to assess the surface and texture to actually feel the lesion. So when you find that the lesions have fine scale, we'll think of pityriasis versicolor, an atrophic or firm patch or plug, we might think of um, lichen sclerosis, and then an infiltrated part, meaning that the patch feels thickened down there, quite firm. We'll think of a lymphoid or granulomatous process. And then we also try to look for evidence of inflammation around the area. So for example, over here we see all of these hypopigmented patches. The surface is evidently quite scaly, well demarcated. So this is typical of pityriasis versicolor. Sometimes the scale is not so pronounced. It might not even be there, but sometimes it's there and it's a clinical clue. You can take this for skin scraping. Now, this is, I think, something that everybody knows is vitiligo. So these are depigmented patches. The overlying surface is actually rather smooth. It won't be much different from a normal skin. Now, look at this picture over here. We find this patch here that is very white in the middle and then more pinkish to the side. And then the periphery is actually dark brown. So this is actually what most inflammatory skin problems tend to be like. When the inflammation goes on long enough, the skin tend to lose color, and then the surrounding area of pink is actually where the inflammation is still going on. But take a look at the texture of this part of the skin. It's a bit wrinkled, a bit like your aluminum foil. Okay, the skin is actually a bit dimpling, so we call this an atrophic patch. So you find that in lichen sclerosis and also some other conditions like morphia. Now over here is something that perhaps everyone would think it can looks like tinea versicolor or something, but if you were to look closer, the borders, some are well demarcated and some are not, and it's actually quite scattered. And if you were to look this at this patch and this patch, the color is slightly different. This is more white, and this is perhaps a little bit more pinkish. This tells you that this, whatever this thing is going on, it is something that's continuing. There are areas where the inflammation is still going on. There are areas where it's barely recovering. Okay, and if you find this in a person in the covered part of their body, elderly gentlemen, you will want to palpate each of these individual lesions because this could be something like a cutaneous T-cell lymphoma. Okay, and this was what I was talking about. All right, so we have already talked about history. We have already talked about assessing the lesions under natural light and Woods lamp, and then also about assessing the surface and texture. So next, we will need to recognize the morphology of the lesions that we are looking at. Okay, so there are four basic morphologies that we should be looking out for. We have the circumscribed pattern, where there are all of these patches or macules which are well demarcated. And then we have a diffuse form where there's generalized hypo or depigmentation. Okay. Compare it with this circumscribed one where it's quite well walled off. This could be at a localized area or scattered area all over the body. And then look at this here where there's this line. So we call them the linear. It may not be a straight line. It can be a curvy, wavy line, or it be even a spiral. And then we have a guttate form, which is like small white speckles that are scattered around a little bit like a confetti type of pigmentation. Hypopigmentation or depigmentation. So why is this important? Because we are going to use this to basically try to break down the different types of diagnosis and differentials. Okay, this is a very simplified table where we try to break down the different types of hypopigmentation and their causes. Okay, it will help to narrow down our differentials rather than panicking and just going blindly for a spot diagnosis. Right. So after that, we will go and talk on about the common diagnosis and then move on to the differentials of each subtype. Right. And this is where we spend most of our time with. So we have a circumscribed pattern. There's hypopigmented and depigmented variant. So let's start off with circumscribed hypopigmentation. The most common cause of that would be post-inflammatory hypopigmentation. You'll see ill-defined, slightly scaly pale macules over a previously inflamed skin. And the underlying inflammatory process could be anything, can be eczema or psoriasis or even trauma, or it can be due to infection as well. Okay, so all of these disease processes, they cause melanin loss, which will manifest as hypo or depigmentation. Sometimes these patches are ill-defined. Sometimes they could be scaly because of the previous inflammatory process. So what you can do is you can use a wood lamp to shine over it. It wouldn't be brilliant white as a vitiligo. It will be just a faint white appearance on wood lamp. And then if you still suspect that it could be fungus, you can scrape some of the scraping and do a KOH stain. Now, management mainly would be to address the underlying inflammatory process of the disease, be it the eczema or psoriasis. Sometimes they might require some steroids, topical steroids, and some emollients, and then some sun protection advice. Now, the important is the differentials. Post-inflammatory hypopigmentation is a relatively benign thing if you tackle the underlying inflammation, but you might not want to miss out other things. All right. So one of the most common other causes will be pityriasis alba or pityriasis versicolor. We're going to talk about it, and then you don't want to miss out leprosy, mycosis fungoides, and then there's this other condition, congenital conditions of nevus depigmentosus and tuberous sclerosis. Pityriasis alba is something that occurs in children and even early adolescents. Okay, although the name is pityriasis, it really has nothing to do with fungal infection. It is actually a mild form of eczema and is often happens on the facial area, the mala eminence. And most of the time, you might get a history of the child having maybe some outdoor activity or sports event, and then the parents think that, maybe the sweat has caused a fungal infection on the face. But it's really because the normal skin becoming darkened that the pale area became more prominent, and the parents become worried. So what you really have to do is to treat the pale area with a mild eczema treatment, emollients, and low potency topicals. And then you want sunscreen so that the normal skin wouldn't darken and the contrast wouldn't be so great. Now, under wood's lamp, you will accentuate the pale area. It would be a faint white accentuation. Now, pityriasis versicolor, on the other hand, is really a fungal infection caused by Malassezia species. There's minimal inflammation. It wouldn't itch as bad as tinea corporis, and it can lead to both hyperpigmentation or hypopigmentation, okay, in darker skin patients. And the lesions can be lighter white or light brown to pink to tan to brown. So there's a variety of colors. So that's why it's called versicolor. Now, in this version, the pigmentation is there, hyperpigmentation, okay, not hypopigmentation, and happens usually in fairer skin patients. If you were to shine a wood lamp, you'll find a yellowish silver appearance of the patches. Okay, we can do a KOH thing where we scrape part of the skin on a glass slide and then we drop 10 to 20% KOH and then we let it dry for around 30 minutes. Or if you have a burner, then you can just run it over for a very brief period and then you can look under the microscope for spaghetti and meatball appearance. It's what we classically describe them, where there is all of these hyphae and also yeast cells that are the meatballs. Nevus depigmentosus is another condition that occurs in 1 in 50 children. It's usually an isolated incident, fairly benign, where you find a hypopigmented patch on usually the truncal area. Okay, so although the name is depigmentosus, it's actually just hypopigmentation. You can find a huge patch and maybe some confetti appearance. These usually do not progress. They grow together with the part of the body that these patches are in. Tuberous sclerosis, if you're taking the exams, then you might want to be familiar with this condition. There are many other extracutaneous manifestations. So we have our chagrin patch, which are leathery skin, and then we have ash leaf macules, which are ovoid in shape, and maybe you have this confetti hypopigmentation. And this condition, I need to spend a bit more time because this is important. Mycosis fungoides is not a fungal infection. It is actually a cutaneous T-cell lymphoma, and it can come in a few morphology. We call them the patch, plug, and tumor stage. So this is the patch stage where there is all of this hypopigmented, ill-defined, or variable border patches, where there are areas where there's clear border, and then there are areas where the border is ill-defined. And sometimes in some of these patches, there might be a wrinkled surface or cigarette paper surface. Now, you will find all of these patches usually in photo-covered area. So if you have a patient that is perhaps a more elderly patient or maybe later in life, and they have all of these patches in covered part of their body, especially in the buttock area, think of MF. In Southeast Asia, we often see a hypopigmented variant of MF, especially among darker skinned individuals. And you will find atypical lymphocytes in skin biopsy because mycosis fungoides is a problem where there are all of these atypical lymphocytes that are zoning into the skin. So that was the patch stage. I just want to show all of you a plug stage of things and also the tumor stage of things. Okay, so this is a patient that I saw recently. This is actually a very huge nodule, and then it actually bleeds. So it's not as innocent as the one just now, the patch stage. Okay, and then we have here something that we don't see often, where there are girls, okay, usually a female in their teenage years, having all of these hypopigmented patches on the back of their trunk. Okay, it's associated with Cutibacterial acne type 3, the ones that cause acne, but this is the type 3 variant, and it's actually a fairly benign condition. If you have a patient with a hypopigmented patch like this, very well demarcated, okay, on the face area especially, and then parts of the body, okay. I know many of us would think that, okay, this is tinea faciei, fungal infection, let's treat with antifungal. Patient doesn't respond, okay, then you need to think hard again, okay. You will really need to actually, yeah, even on the first examination, you really need to think of examining the ears, the eyebrow, and other parts to look for hypoesthesia because this is leprosy, right? So test the sensation. The sensation may be present, but make sure you don't miss it out. Okay, and then of course there are other conditions like chemical leukoderma, where you can have a loss of pigment because of exposure to products that are being used. For example, this person using rubber goggles, hair dyes containing PPD, paraphenylene diamine, cosmetics, synthetic leather, rubber, and so on. Okay, and then there's circumscribed pattern where there's depigmentation. Okay, vitiligo is the most common cause, affects 1% of people worldwide, and we can see patients with just macules or even large patches like that. This is a disease that's associated with other autoimmune conditions like thyroiditis, type 1 diabetes, and pernicious anemia. Now, it can occur in a generalized pattern, okay? For example, like Michael Jackson, or symmetrical pattern, certain areas of the body, or even just a unilateral area, segmental and focal area. On Wood's lamp, it will accentuate as a bright white patches. Management would consist of topical steroids, things to medications to target the inflammatory process. And lately, JAK inhibitors has been used with success. Other ways is to use localized phototherapy or even a generous phototherapy if patient is badly affected, and excimer laser, and sometimes we might have to resort to cosmetic camouflage. differentials of depigmented patches are important. So we have over here hypopigmentation and Waldenburg syndrome. These are both autosomal dominant syndromes where there is areas of depigmentation and a white forelock. In Waldenburg, hypopigmentation is actually just an isolated cutaneous problem. But in Waldenburg syndrome, you might have sensory neural deafness and heterochromia iridis, where you see this part of the pupil, part of it is different color. So incomplete coloration of the iris, okay? And then there are acquired disorders like chemical leukoderma and leukoderma of scleroderma. So piebaldism and Waardenburg syndrome, you might see depigmented patch like that with white hair, white fallout, we call them. And then you can even find this on other parts of the body that are stable and sharply demarcated depigmented patches. So we move on to diffuse form of hypo or depigmentation, the most common being albinism. The complete term is ocular cutaneous albinism. So OCA, there are four main variants. Variant 1 and 2 constitute 90% of the cases. So what we need to know is it doesn't just affect the skin. Every area where there is melanocyte will be affected. So the skin and the eyes as well. So there are also other features such as eye problems, nystagmus, photophobia, and reduced visual acuity as well. And patients like this require genetic counseling. They will require a lot of sun protection. I'll tell you why in a second. So patients may present with pure absence of melanocytes or just partial absence of melanocytes. So that's why can have patients that may have pale silvery hair, or their hair color is intact. It's just parts of their skin. So you have a wide phenotype of patients. Okay, and some of them might have translucent iris, so you can see that their eye color is no longer black or brown or blue. And these patients, although they may appear fair, we always go after fair looking appearance. They have they lack that protection from melanins. So all the ultraviolet rays will go directly into their skin and damage their DNA. So there'll be a lot of pigmentation risk and also risk of developing skin cancer, which are aggressive. Okay, so these are the four main subtypes. I won't talk much about them. There are other congenital conditions where you have depigmented skin as well. These are all conditions that may cause melanosome transfer problems or even productions of melanin. So we have Hammerstein Pudlak, Chedak-Higashi, Griscelli syndrome, okay? And then we have universal vitiligo and deficiency of B12 and zinc. B12 and zinc are actually involved in the synthesis of melanin from the conversion of tyrosine to melanin pigments. So when you have a deficiency of this, they may present with hypo or depigmented patches. So as for congenital, they may appear just like a patient with albinism with varying pigment loss, but the difference is that they tend to have bleeding diastasis, these three conditions. Right? And then we have a linear form where there is whether there's Blaschko pattern or not. So if the linear patterns follow Blaschko's line, then we have linear nevus, hypopigmentation, and incontinentia pigmenti. Okay, and then we have acquired forms where there's inflammatory process like lichen sclerosis or even post-injection hypopigmentation. Okay, so what are Blaschko's line? So in the early form, when we are when in the mother's womb, when the cells are of the embryo is just forming, so the early cells may undergo maybe some part of the skin cells actually start mutating, and that mutated cell keeps on replicating and migrate along embryological lines, which are lines that are along that they migrate along the lines on the surface of our body to go to different parts of the body from. So if just say you have a mutated cell that migrates along one of these lines, that's what we call a Blaschkoid pattern, and that's how the Blaschko's how these hypopigmented Blaschkoid lines form. Okay, so it's usually an isolated event where there might not be other manifestation. But if there is, for example, seizures or even other cranial central nervous system issues, then think of hypomelanosis of Ito, they will have this type of blush called hypopigmentation with systemic manifestation. Another condition is incontinentia pigmenti, having a difficult time pronouncing this word. It's actually a genetic mutation of the NEMO gene and is X-linked recessive. It has 4 stages. So these first 3 stages happens in childhood, and this one until 20 years old. So there's vesicular and varicose form. Most of us may not have seen it. And then hyperpigmentation, and later in life, hypopigmentation. Okay, it is associated also with alopecia and also denture issues. So if you have patients with all of these streaks of hypo and hypopigmentation, look hard for examine their hair, examine their teeth as well. And if there's even a history of miscarriage in the family, because the male embryos usually don't survive, it's usually only female patients that acquire this. Right? And then lastly, I'm going to talk about gutted form of hypopigmentation. So gutted pattern, as the name suggests, it's more of like a confetti hypopigmentation. The most common being idiopathic gutted hypomelanosis. It's a very common thing that we see. Some of us may already have it, and it comes with age, where there is just multiple small, well-circumscribed white macules. Okay, and then there are other confetti type of lesions in tuberous sclerosis or even lichen sclerosis and pityriasis lichenoides chronica, which are inflammatory conditions that can present as scattered small macules or patches. So remember, beyond the skin, examine the hair, examine the teeth, um, check for sweat, especially in leprosy. When you think of leprosy, check for sensation in leprosy. If a monofilament is available to you, you can use that to test, or else a bedside test would be to use a ballpoint pen as a very rough screening for sensation loss. Right? And these are the red flags we have to think of when there's already sensory or nerve thickening. When the patch of plaque is indurated, we find it thickened. It might not just be a normal leukoderma or something innocent. It can be lymphoma or even an autoimmune condition like morphia going on. For that, we really need to biopsy them. Okay. And then if the condition is rapidly progressing, okay, some vitiligo are very active, you will need to institute some systemic steroid treatment. And then if there are systemic findings, extracutaneous findings that might tie into other syndromes, and also when all of these are causing psychological distress. So these are the cases you want to refer to dermatologists. So to summarize, so bedside evaluation other than history and examination. So we have to we are encouraged to examine the wood slime is available. We can take the skin scraping for fungal culture or even KOH staining. Then we test the sensation, and then if really unclear, okay, not every diagnosis will be available to you at the bedside. Some, even after you have done everything, you're still not sure. You have a list of differentials, then you biopsy it. Okay, and I refer to us to do that. All right. So in summary, these are the things that we have talked about. Okay, confirm there is a hypopigmentation, examine the surface, go by a morphology recognition, look for extra cutaneous clues, do simple tests, and look for the red flags. And this is the table that I was talking about just now, right? And that's all I have to say. Happy to take any questions.
Hi, Dr. Gary. Let me see, where is it now? Cannot see. Can you see? I cannot see you, Gary. Okay, can see you. All right, that was really good, Gary. Comprehensive, and I made notes along the way. So basically, to summarize and to recap what you've said, hypopigmentation is basically the pathological condition that could be involving the melanoblast migration or melanosome biosynthesis or even transfer, correct? And then when we see hypopigmented lesion, we want to assess the morphology, of the lesion, to look at the surface of the lesion. And then we want to proceed with the Woods lamp examination to tell whether it's hypopigmented or depigmented. Okay, and then of course you want to step back and have a look at the pattern and distribution of the lesion, and not to forget to check for the sensation. And if it's more generalized, also look for the teeth and the hair. Okay, so that's to take. You mentioned about scraping and the KOH, bedside KOH test. Apart from the skin scraping, we can also do a basic simple tape test by using the taping. Just tape it over the skin, and then same as like scraping, drop KOH on the slides, then place the tape over the slides and look under the microscope. All right.
Yeah.
I particularly like the slides that you summarize about the red flags. Basically, that's when you want to refer any case of the suspect, any unsure case to dermatologists. If you see indurated hypopigmented lesion, or if you have a hypopigmented lesion with hypoesthesia, or even sensation loss, okay, then you want to refer to dermatologist, because when we suspect leprosy, not all lesion has loss of sensation. Some lesion still have sensation intact, but some of the lesion you will realize is hypoesthesia, and that's the most common presentation. We don't go like every lesion has no sensation. No, it doesn't present in that way. Yeah, some of the lesion you have sensation intact still. And then about this rapidly progressive hypopigmentation, lesion with systemic symptom, as well as any psychological distress. We have got a few questions here, Dr. Gary. Just project to you. How do we differentiate pityriasis alba versus tinea versicolor on the face?
Right. That's a very excellent practical question. But first of all, thank you for the summary. That's very succinct, and I think you have a photographic memory. Right. So, okay. So, pityriasis alba and pityriasis versicolor. One is an eczematous condition, and one is fungal infection. So, the direction of treatment is totally different. So, I understand where this question is coming from, because sometimes it can get confusing even for dermatologists to differentiate these two. But I would say that pityriasis alba is something that is more gradual. And if you were to say it more clinically, patients might present with a recent history of sun exposure. That's why the normal skin becomes darker. And the lesions themselves, pityriasis alba would have a more ill-defined border, more fuzzy border compared to a versicolor where the borders are well demarcated and it could be a cluster of coins together. That's how I say it in pityriasis versicolor. So, Dr. Go mentioned just now, you can do something called a tape test. We can take a cellophane tape, and then we just paste it multiple times on the pale areas. And then we can take a Parker ink, the one that we get from stationery shops, and then we stain it, and then we look for it under the microscope. That's why we can look for this spaghetti and meatballs.
Yes.
Yeah.
So I hope the answer is clear enough. And there's so there are questions at the Q&A session here. In case the topical steroid and sunscreen is needed to be applied, and patient is applying skincare products, serum, toner, moisturizers as well. In what sequence of the product application would you recommend, and what is the rationale behind the sequence? This is a little bit out of our question today, but I'm sure Dr. Gary can answer you well.
That's a very good question. I was just asked this question yesterday by another patient as well. So, moisturizer first or sunscreen first? Logic dictates that sunscreen has ultraviolet filters, and these filters need to bind to our skin to become active. So we would tell patients to apply them 30 minutes before going out. So if you were to apply moisturizer first and then you apply sunscreen, logically that filter might not bind to your skin. But nowadays, with modern with science advancement, that's no longer a problem, and you can apply your sunscreen after your moisturizer, and it will just work as well. So in the past, I wouldn't advise that, but recent new sunscreen, you can do that already. So it doesn't really matter which sequence because they both will work. The only issue that I foresee is that some moisturizers, when they come into contact with your sunscreen, they tend to clump. You know, you get that sandy and gritty feeling when you apply both together, when two products. So if that happens, you might not want to use these two together, or you might want to apply them at different times rather than together at one time.
Correct, correct. And
Yeah.
some sunscreen, after application, you need to tap it a little gently to the skin to avoid the clumpiness sensation. So if you then it will blend in nicely with your skin. Okay. Next question, Dr. Gary, just curious, many people say they have birthmarks which appear as isolated hypopigmented patches. Can this merely be considered normal, not requiring workout, if not associated with any other symptoms?
Isolated birthmarks. I would still advise for proper examination. Okay, so if that birthmark is if that birthmark is referring to an isolated hypopigmented patch, not progressing, or perhaps even just growing together with the body part, like from a child to adulthood, it doesn't just have a sudden life of its own, outpacing the growth of the surrounding length of the limbs, for example. Then I would say that that is probably something like more of a cosmetic concern. However, if it's a condition where you have one and then you have a few others appearing, then that no longer becomes something that is a birthmark. Okay, so you may have another condition that occurs hypopigmented as well on top of your birthmark. So get it examined if it's progressive, even if you think that there's no other extra cutaneous manifestation.
Yeah. So we look at the progression, we look at the history back. So a lot of time, the so-called birthmark is not really birthmark. If we really go back to the history, and since when we really are, they just say this one has been there for many years. It is so-called birthmark to them. But if we ask back the question, we realize actually it's not really birthmark. They acquire it later in life, maybe like during primary school or secondary school. So that's strictly is not birthmark. So history is very important. So that's a new rising symptom. If birthmark, yes, then we look more on the progression. Then most of the time it's rather benign. If it's something like it comes on like later on in life, like primary or secondary school, then you really want to assess it. You take back the history, you assess the morphology, you do all the necessary investigations and bedside assessment.
Yeah. Some conditions like hypomelanosis of Ito and so on, they may present only during your teenage years. Okay, so get it confirmed first because if it's just like I said, if it's just something that limited to the skin occurring in teenage years, you may not have to do anything. But if it's something progressive, then we need to really check it again.
Correct. Progression is very important. And then, so next question will be, can I clarify when we should suspect and treat for fungal infection in the case of hypopigmented skin lesion?
I would suspect a fungal infection if again it's progress and then the area that's involved. Fungal infection tend to occur in sweaty areas of the body, especially covered areas, and they tend to have a scaly surface, and there would be more of hypopigmentation rather than depigmentation, and the borders are well demarcated. Having said that, I've only showed you pityriasis versicolor. There are other types such as tinea corporis or tinea fasciae, where it's caused by trichophyton or other types of dermatophytes, where they have a very erythematous, angry-looking ring. okay, that can sometimes mimic even leprosy. Okay, and then there are also other types of fungal infection that is indurated subcutaneous form. So when you see that something is expanding with an angry border, you should also think of fungal infection.
Okay.
Yeah.
And then there's another question out of the topic today. Is patch test widely available in Malaysia? If yes, which centers are offering the service?
Right. So patch tests are offered in a few what do you say? Some mainly in tertiary hospitals like in Johor Bahru, and then Muar Hospital as well, and then also in Hospital Kuala Lumpur, Selayang, and Ipoh hospitals, Penang. So I think the main hospitals would have it. So the main issue is that when we do patch tests, we need to bring in the allergens with import permit, and the so if just say we were to do a whole panel of 32 allergens, the whole thing will cost maybe around like easily 10 or 15,000. So that's why it's usually done in high volume centers because these allergens, they have a expiry date. They only last maybe 2 years, maybe 3 years. So you might not even be able to finish using it by the time of expiry. But yeah, it's available in many of the big tertiary centers and also some private hospitals as well.
Yes, that's right. How about what are the indications for IgE and IgG blood tests since it is not recommended to be done to anyone?
IgE blood test is a very good question. It's an allergen IgE blood test, I assume. So to really understand it, we need to know about our hypersensitivity reaction. We have type 1, then 2, 3, and 4, type 4 hypersensitivity. So when you have eczema, you have contact dermatitis, that's more of a type 4 hypersensitivity reaction. And invariably, those type of hypersensitivity reaction is more related to our what we call our Th2 immune system, lymphocytes, that type of pathway, rather than IgE or histaminic pathway. So type 1 hypersensitivity is related to IgE and also our histamines and basophils and so on. So that would be more related to perhaps urticaria or even food-induced or drug allergies and so on, or even anaphylaxis. So if I have a patient with chronic recurrent urticaria, I will order this IgE test. If I have a child who gives me a very clear history, she has eczema perhaps, and keeps on being triggered, okay, by certain things like maybe pollens, grass, or even food, okay, there may be a role for IgE testing. But I would say that almost 90% of patients with eczema or contact dermatitis, they don't require IgE testing. I would rather go for patch testing if I suspect allergic contact dermatitis or unexplained eczema that doesn't improve.
Yes, yes, I agree with Dr. Gary. So we use the RAS test, the Ig immunoglobulin test, the Ig test, IgE test to confirm an allergy. We do not use it for screening because even if I do it, I may have positive result which I do not manifest any symptoms. So we use it to confirm, and also if the result is negative, then it can safely rule out allergy reaction for the patient. All right.
Yeah,
Okay.
that's right.
Yes. So I think the time is running out. So this will be the last question to Dr. Gary. In a 70-year-old male with hypothyroid and mild diabetes develops vitiligo of lips and fingers, what treatment is suitable?
Vitiligo of lips and fingers. A 70 years old patient. So um I will first like to determine how long has the lesions been, because okay, first of all, depigmented patches on the lips and fingers other than vitiligo, it could still be chemical leukoderma. These are areas of high friction, high contact with um external stimuli, right? So and if it's something that if just say I have to rule out that is chemical leukoderma, then I would think of how long has this lesion been? and has this lesion stopped being active and already stable? Because if just say this is something that just occurred maybe in a few months, then there may be a role to stop the inflammation. We can go for a calcineurin inhibitor for the lips and even potent steroids for the hands. But if something that has been stable, not moving, not progressing, and has been there for 1 year or 2 years, I may not proceed with any treatment because the treatment might not help me gain back that pigmentation. So it really depends. So we first need to confirm the diagnosis of what's causing it. And then secondly, how long has it been?
Hey, thank you so much, Dr. Gary. It has been a very, very insightful sharing session, and I especially love the
Thank you.
questions that we have today with our attendees. Do you have any final words? I mean, the last words to summarize? Okay, when to refer?
Right.
When can they refer everything that's unsure to dermatologists?
If you are unsure, obviously you need to refer because you cannot be wasting patients' time and also resources like giving fungal treatment and so on. So yeah.
Correct. We welcome referrals. We welcome referrals in general. Okay, so with this, we'd like to sum up our session today. I shall pass the baton back to Dr. Liu.
All right, thank you, Dr. Go and Dr. Gary. I think we'll bring this session to a close. Thank you, everyone, to attend this session today. Right, thank you. You can
Thank
leave
you.
already.
Right. Thank you.
Hi, thank you.
Bye.
Well done, well done.
Thanks.